Welcome to our podcast on the topic of data dilemmas, ethics, and health sharing, where we dive deep into the most pressing and complex issues shaping our world today. I am Kamyen Chia, and I am joined by my co-host Kushini. In today's episode, we are tackling a topic at the intersection of technology, ethics, and healthcare: the ethics of health data sharing. In an age where health data is a valuable asset, balancing the potential benefits for public health with the imperative to protect individual privacy presents a challenging ethical landscape. As we explore this topic, we will delve into questions surrounding consent, data ownership, and the fine line between progress and privacy. Joining us today is Professor Chia Fei Yong. She is a professor of global health and bioethics at the University of Oxford, the founder and current head of bioethics and engagement at the Medill Oxford Tropical Medicine Research Unit. One of her areas of research is how to promote fair and equitable sharing of health research data, so she is very well qualified to navigate us on the ethical dilemmas that arise when sharing health data and how we can ensure that this powerful resource is used responsibly and equitably. Firstly, we will explore the background of health data sharing. Professor Xia, what is health data?
Thank you for your question, and thank you for inviting me. So what do we consider health data? So this is our data that is collected routinely in hospitals, in clinics. It also can be research data, health research data, data collected from clinical trials, surveys, qualitative studies. And nowadays, wearable data, although you don't see it as directly health data, can be health data, because wearable data get your heart rate, and things like that. So actually, they can be considered health data. And when we talk about health data, we usually mean de-identified individual level health data. So this is not aggregate data, and it is not it doesn't have the obvious personal information. It's de-identified, and I'll explain a little bit about the de-identification later on.
What is health data sharing?
So what this means is making data, individual level data, the data I'm talking about, available to secondary users. So these are users that is not within your primary research team, or within if it's a hospital data, not within your hospital or your research group. So imagine sharing data with, you can say, outsiders. It really depends on what you mean by outsiders, but sharing data more widely. And this is not for that particular patient's clinical care. This is for wider use.
What gave rise to health data sharing?
So there is an evolution of making research more accessible and more open. So about making clinical papers, academic papers, open access. So it kind of follows that trend. So it's now come to health data or research data. So this is to increase public trust in research. So people want to see what data you have for you to arrive to that conclusion. We also want to some people also want to verify the results of a particular study, but we also want to maximize data use, because research data, especially clinical trials data, is very expensive to collect. It's very valuable. So the more you use it, the better value it is, so that we maximize data use, minimize research waste. And sometimes if you combine data sets, you can get more powerful data sets, which means you can see trends better. You can, ultimately, hopefully, improving science and health.
Who owns health data once it is collected?
That's a very good question, because if you ask, it depends on who you ask. If you ask different people, you can get different answers. But from my research, there's a handful of contenders for who owns the data. Some people say it's the patient or the participant or data subject. Okay, if it's belongs to the public, does it belong to the investigator, or you mean the researcher collecting the data, or does it belong to the institution of the data collector. So let's say it is University Malaya researcher. So it doesn't belong to the researcher, but it belongs to University Malaya. So that is one option. Some people also say it belongs to the country. If it's data from Malaysia, it belongs to Malaysia. Some people say it belongs to the funder, the people who fund the project or the research. And some people say it belongs to the sponsor of the study, the legal entity that has conducted the study. So in the sense of pharmaceutical companies, they fund and sponsor the study, they would say the data belongs to them. Okay, so there are many contenders. For me, I think this discussion is not about ownership, is not very helpful because let's say the data owns by X. But actually what you want to ask is, who has the right to do things to the data, right? And I would say the more important party is the custodian of the data, who looks after that particular data set. All right. So maybe we move on and then I can illustrate a little bit better later.
What are the common examples of health data?
So as I mentioned just now, health data can be various forms, but I guess the examples can be data sets from ministries of health, data sets sitting in registries. So I think Malaysia has a cancer registry, has this and other different types of registry. So those are examples of data. And pharmaceutical companies from their clinical trials, they have a lot of data. So these are some examples.
How effective is data anonymization in protecting individual privacy?
Okay, so just now I mentioned the word de-identification. Um, for me, there's a difference between anonymization and de-identification. So anonymization would give you an impression that you strip off everything that can identify a person. Okay, and this is quite hard to do, right? So I'm not a technical person, so let's park it there. And some people use the word de-identification. You just take out names, address. If you have a hospital registration number, you take that off. And that we call de-identification. So sometimes if you have one de-identified data set, you combine it with another de-identified data set. Some computers, some systems can match the two and re-identify the participant or the patient. So fully anonymization is quite difficult and it can be done, but it's quite difficult. And I would say that if it is done to a certain extent that you really are very, very sure you cannot re-identify the participant, it may be that the data set is not so useful anymore. Let's say you have a data set on somebody with a data set of people with diabetes. You take away the location, you take away the ethnicity, you take away all that, then it becomes quite meaningless. So to your question, what was your question? How effective is data anonymization?
Yes.
Um, yeah, I mean, there are multiple answers to that, and I've illustrated why it can be, how it can be done, but it may not be that useful, and it's more useful to don't anonymize everything because then the data set becomes useless. Also, technology changes. You can't foresee in the future. They may come up with tools that can re-identify patients quite easily, right? Yeah. So that's a long answer to your question.
Considering the above, do you agree that individuals should have the right to control how their health data is used and shared?
Okay, again, no straight answer there. So control is okay, let's look at what do you mean by control. So if you ask, so you can ask a participant to consent for their data to be used for a specific purpose now. But you can also ask the participant to consent for future use within the realm of a specific project, or you can say specific scientific areas. You can maybe confine it. So if somebody were to give research for malaria research, let's say, malaria research 1 and malaria research 2 in the future, or malaria research 3 in the far future, if the participants say, okay, I'm happy for you to use that, then that's a certain control as well. So we call that consent broad consent. Okay. I meant some people think blanket consent is also an option. Maybe I give you the data for the research now and anything else you want to do in the future. So some people may agree to that, but some people won't. So it really depends on what type of control you would like. It's an individual preference, more or less. But I would say asking people to consent per study is going to be too difficult, and that participant may not know what is going to happen in the future, and it may be more harmful to keep going back to the same participant. They may think, oh, what's happening? Why do you keep contacting me? Am I in trouble? So it may be more harmful. So my personal belief is that you can ask participants to give you broad consent for users in the future. And these users in the future cannot be just anything. It can be confined to, let's say, research meant to improve a certain, health or whatever. And that research should be approved by, let's say, a data custodian. And a data custodian can be a data access committee. Sometimes it can be the research ethics committee itself. But in some places, there's a different committee reviewing data access requests. So let's say where I work, Mahidol Oxford Research Unit, we have our own data access committee. So we don't go back to each participant every time we want to reuse the data. The data access committee will review and say, okay, this fits within the sort of the main area of the research that the patient originally consented to and has given broad consent. So therefore it is okay. If let's say I collect data for malaria and another user wants to use it for, to look at migration patterns for this particular population, oh, that's really weird. I think the participant will not like it because they didn't really consent to that. So I would say, so in summary, a managed access route would be good. So control, yes, to a certain extent, but not individual study.
Thank you so much for explaining health data sharing, Professor Xia. I will now pass the floor to my co-host Kushini, who will be exploring the second part of this podcast, concerns surrounding health data sharing. Miss Ku, the floor is yours.
Thank you so much, Yansha. Good afternoon, Professor Chia. Now that we have covered the basics, let's move on to some of the broader implications. There's no doubt that sharing health data can have tremendous benefits, but what are the legal and ethical implications of data health sharing?
So let's start with legal. Now, legal would depend on each jurisdiction, as you know, as legal scholars. But most countries, I would imagine, will have a Data Protection Act. The Data Protection Act will govern health data too, and health data sharing. So health data is one of the special category data or sensitive data. And you need to follow the laws in that country. Now, this is quite tricky because Data Protection Act in most countries, they pertain to personal data, which means data that you can identify a patient with, right? So as I mentioned just now, the degree of anonymization or de-identification varies, and it may change once technology changes, okay? So when you say you've de-identified somebody and you think it does not fall under Data Protection Act, it may not be true because technology may change. So I think that the first question is what the legal status of legal regulations in place in that country. So that's number one. Second thing I mentioned is just now you asked me about data ownership. So I believe in some countries, data is owned by the country. So if you want to export data to another country, there may be extra approvals you need to have in place. So these are some of the legal issues. In terms of, did you also ask ethical implications, right? Okay, so firstly is the risk of re-identification. So one thing I like to promote is not having data open access, completely open access, even though they are de-identified, because there's a risk of re-identification and the risk of harming participants. So it can be some ethical implications might be potential harms to the participants, either individually or as a group. So if you study a group of participants in a small village who has a certain disease, they may be stigmatized if the location is exposed. Even though the individuals are not exposed, the location is exposed, they may face harms. Also, I want to spend a few minutes talking about the primary researchers. Primary researchers who collect the data, they have a stake in that data set. So if that data set is shared for anybody to use, then there's an ethical issue there, because this poor researcher has collected all the data and has spent time and effort collecting the data, and now they have to share data with everybody else who can just wait and use the data, right? So this is especially important when data is collected by researchers in developing countries or low and middle income countries, and from communities in low and middle income countries. So once the data is out there, it can be used by people in high income settings very quickly. That risks exacerbating existing inequalities between researchers in high income and low income settings. So this is a real issue because there's already a big disparity. So you don't want to further widen the disparity between researchers in high income setting and low resource settings, right? So one more thing that's important here, secondary users may not really understand the context of the primary research or the communities. So data can be taken out of context and can be misinterpreted. So that is one danger of data sharing. Unless the primary researcher is involved in the secondary research as well, or secondary analysis as well, then the risk is high that the research, the data can be taken out of context and reanalyzed in a way that might give you a different conclusion or wrong conclusion. I think that's it for now.
I see. Thank you for your clarification. Moving
Would
on, new technologies like AI and big data analytics transform the ethics of health data sharing?
Yeah, I think it will. So one thing that I mentioned was a re-identification of participants that or that you think you have de-identified. You might be able to re-identify people earlier. And the other concern that I would have is, if let's say you are asked, would you share or give your data to somebody working on AI? So that participant has agreed to his or her data to be used, but actually the implications are wider. It involves people who did not consent to it, because the data that you give has been used to train an algorithm that will affect other people. So this is one implication that it's going to be quite difficult to solve. So existing research ethics committee is unable to mitigate that kind of harms that could happen from AI research.
How do we strike a balance between the need for individual privacy with potential benefits of health data sharing for public health advancements?
So my view is we should have a managed access system. So whenever you finish a piece of work, or let's say you have a good data set collected from a registry or a hospital. So imagine you have data sets, right? So the data sets have de-identified individual level data. So they are they're almost ready to be used. And you don't want them to sit there, because then you are wasting resources. So what people can do is apply to use the data sets. they apply to a committee. The committee can be a data access committee, can be a research ethics committee, can be the hospital committee or whatever that makes sense. And the secondary user who wants to use the data should say, I want to use the data for A, B, C, D. And this is the data set, and this is what I'll do. So if the objective is clear, and the data access committee or custodian has approved it, then they should sign an agreement. The requester should sign an agreement with the data provider to say that I will use the data for A, B, C, and D, and then nothing else. And when I publish the paper, I will credit, this institution. And hopefully the paper will be published open access, and then the results will be useful. So, but before that, we must ensure that the data set can only have data from participants who have given consent to broad data sharing. So this is the way I think we can handle it. We can maximize data use while mitigating harms. So the data access committee will probably have to say no if they think the analysis will cause distress or harm to the participants or participants' communities, right? And if necessary, we say, okay, maybe this data is collected from a community in Malaysia, maybe remote community. So if you don't understand it, if you use the data set without any help, you won't understand the context. So one way is to say, okay, you can have the data set, but we would like to participate in the analysis so that we can give you the background. You can maybe visit the place. We have this kind of collaborations in place. Then the data hopefully will not be taken out of context, and they will be able to analyze the data set in a more effective manner, an ethical manner.
Thank you so much, Professor. Let's move into the last subtopic of today's podcast. So, building trust in health data sharing. So, the next question is, what steps should healthcare providers take to strengthen the trust between the patients and themselves with regard to health data sharing?
So, I think collecting, I think we need to, patients or participants need to understand what they have been asked for, what data they have been asked for, and what secondary users there might be. So this might be a bit difficult to explain. So the healthcare provider or the researcher needs to explain a little bit. But I would also say that there should be a wider discussion. So because during the one-to-one transaction, it might be a bit overwhelming. But if the general public is already aware that this happens, then it is easier when you have that one-to-one discussion with that particular participant or patient in the hospital. So I would propose that we maybe raise a bit more awareness of health data sharing among communities in the public. We also want to aware what data is actually considered sensitive to that community. So, Malaysians may be worried about revealing certain information. Some communities may be worried about revealing data about, I don't know, it really depends on political context, their health situation, things like that. So religion is another one as well. So I would say understand the community, understand what they are worried about, what is sensitive to them. Because sometimes in the regulations, they say, okay, health data is sensitive. Really, data on religion is sensitive. But what about other things? I think I had a chat with one of the communities I work with. They're worried about sharing income data. They don't want people to know about their pay. So, okay, that's sensitive data. So we must understand the views of and perceptions of that community before, in order to build trust.
Last but not least, what are the best practices you will recommend for sharing health data ethically and responsibly?
So I would reiterate that you have a mechanism in place for reviewing a request of data sets. Okay, so the data custodian role, have a mechanism or have a good broad consent process. Okay, so ask people for individual consent for specific studies and broad consent for future studies, right? And when you hand over the data set to a third party, have agreements in place. So 3 key takeaways, okay?
Thank you so much, Professor, for joining us today and sharing your invaluable insights on the ethics of health data sharing. Your expertise and compassion have shed light on such an important and sensitive topic, and we truly appreciate the time and effort you have taken to be with us. Once again, thank you for being here and contributing to this vital conversation.
Thank you. Thank you for having me.